chronic spine pain. It's a huge problem, right?
Oh, absolutely massive. Millions deal with it worldwide, and it just messes with everything.
Yeah, like just getting dressed, sleeping properly.
Exactly. And, for a lot of people, when the usual things PT, meds aren't cutting it.
Then they start looking at these procedures, like injections or nerve ablations.
Yeah, those interventional approaches, things like injections or using heat to kind of zap the nerves.
Right.
And you've seen a massive increase in how often these are used the last couple of decades, especially.
It seems really common now.
Super common. But here's the thing, the kind of surprising part. Despite how widespread they are, how much they cost, there's actually been a lot of disagreement, uncertainty in the medical world about how well they really work.
Which feels kind of wild, doesn't it, considering how many people get them and the expense involved?
Exactly.
So that's precisely what we're diving into today. We've got this stack of sources, mostly centered around a big splash in the BMJ.
The British Medical Journal, yeah.
They put out a series recently, a really rigorous, large-scale review of the evidence, and a new guideline based on it, taking a super close look at these common spine procedures.
So our mission today is really to unpack what this BMJ deep dive found. Do these procedures actually help with chronic spine pain, the kind that isn't cancer-related?
Right. And weigh that against the downsides, the costs.
And then explore the reaction, because, well, it's been pretty intense for doctors, from patients.
Okay, let's get into it. First off, just so we're all on the same page, what exactly is chronic spine pain in this context?
Good point. So here it means pain that's been hanging around for at least 3 months, chronic.
3 months or more, got it.
And it mainly falls into two types. There's axial pain, that's pain felt right, in the spine itself, localized.
Okay.
Or radicular pain, that's the kind that shoots down an arm or a leg. Usually means a nerve is getting pinched or irritated somewhere along the spine.
Like sciatica, that kind of thing?
It's exactly like sciatica. And the procedures the BMJ sources we're looking at are the ones you hear about quite a bit.
Like what?
Well, you've got joint-targeted injections. These go into the little facet joints between the vertebrae or the sacroiliac joints, kind of lower down near the pelvis.
And they inject, what, just anesthetic?
Usually local anesthetic, sometimes steroids, often both together.
Okay, what else?
Then there are epidural injections. Those go into the epidural space around the spinal cord.
Ah, I've heard of those.
Yeah, they can do them in the neck cervical spine, the lower back, lumbar, or even right down at the tailbone of the caudal area. Again, using local anesthetic, steroids, or both.
Seems like steroids are pretty common in these.
They are, yeah. Then you have the radiofrequency procedures. This is different.
How so?
This is where they use heat generated by radio waves to target specific nerves. The idea is to disrupt the pain signals.
So like burning the nerve ending.
Kind of, yeah. It's often called nerve ablation or denervation.
Yeah.
They might target the nerves around those facet joints, or a structure called the dorsal root ganglion, which is involved in transmitting pain signals.
Okay, nerve zapping. Got it. Anything else?
One more main category they reviewed, paravertebral intramuscular injections. Basically, injecting anesthetic or steroids into the muscles right next to the spine.
All right. So those are the main players: joint injections, epidurals, radiofrequency, and muscle injections.
Those are the ones the BMJ review focused on, yeah.
Yeah.
And just to set the stage a bit more, understanding why this review caused such a stir, you have to look at how common these procedures have become.
The sources really hit that point hard, didn't they? The growth has been huge.
Staggering, really. You see numbers like, I think it was a 271% increase in lumbar epidural steroid injections in the U.S. just between the mid-90s and early 2000s.
Wow.
And lumbar radiofrequency procedures also shot up dramatically.
Yeah.
And naturally, you see more and more doctors actually performing these procedures too.
And the cost. That's a big part of the picture.
Oh, definitely. The sources mention figures like average annual billings for pain doctors doing nerve blocks hitting over, what was it, $700,000 in Ontario a few years back.
700,000. That's a lot.
It is. And, it inevitably raises questions about financial incentives. Could that play a role in how often these are recommended or done?
It just adds another layer of complexity, doesn't it? Especially when you remember, like you said, that even before this big BMJ review, different medical groups had conflicting guidelines.
Exactly. There wasn't clear consensus. Some guidelines supported certain procedures, others didn't, or only in very specific situations. It left a lot of people, doctors and patients, kind of unsure.
So it's this landscape of like widespread use, big money, but shaky agreement on effectiveness.
Precisely. And into that steps the BMJ's Rapid Recommendations Project.
What's the deal with that? Rapid recommendations.
Their whole goal is to accelerate getting trustworthy, evidence-based recommendations into clinical practice faster than usual guidelines might.
Okay, makes sense.
And how they put this specific guideline together is really key to understanding its weight and, well, the reaction to it.
How so?
Well, the panel wasn't just, a bunch of specialists in a room. It was international diverse.
Yeah.
Included clinicians, obviously, research methodologists.
Standard stuff for a guideline panel.
Right. But critically, it also included people who actually live with chronic spine pain, patient partners.
Ah, that's interesting. How did that change things?
Hugely important. They help define what outcomes really matter to patients. It's not just about a pain score number, right?
No, it's about daily life.
Exactly. So they focus on pain relief. Yes, that was critical. But also things like physical function, emotional well-being, social life, being able to work or do your roles, sleep quality, whether you're using opioids.
And side effects too, presumably.
Definitely. Adverse events. They wanted a holistic view of what makes a difference. And importantly, they made a real effort to select panel members with minimal conflicts of interest.
Okay, so diverse panel, patient input, minimizing bias. What evidence did they actually look at?
It was immense. The main driver was this massive linked systematic review and something called a network meta-analysis.
Whoa, okay. Systematic review, that means they pull together all the relevant studies, right? Very thorough.
Super thorough. They found 81 randomized controlled trials, RCTs, which are usually considered the best type of study design. Altogether, these involved almost 8,000 patients.
8,000 patients, that's a lot of data. And the network meta-analysis part, it sounds complex.
It is a bit fancy, statistically speaking, but the basic idea is it lets you compare many different treatments against each other all at once, even if, say, treatment A was never directly compared to treatment C in a single trial, but both were compared to treatment B.
Network analysis can kind of figure out how A stacks up against C.
Exactly. It synthesizes all that indirect evidence along with the direct comparisons. It's a powerful tool when you have lots of studies on different but related interventions.
Okay, so they took those 81 trials, ran this network analysis. What else?
They also looked at a separate systematic review that focused specifically on the harms reported in observational studies, because trials aren't always the best at capturing rare side effects.
Right.
And they used a method called GRADE to assess everything.
Great.
Yeah, GRADE. Think of it as a formal system for rating how confident we can be in the evidence for each specific outcome. Is the evidence high certainty, moderate, low, or very low certainty?
So it's not just what the studies say, but how much trust we can put in those findings.
Precisely. And crucially, they compare the active procedures against either sham procedures like a placebo injection or just usual care.
Oh, okay. So incredibly rigorous process, huge amount of data, focus on patient outcomes, assessing certainty. What did they actually find? This feels like the main event.
It really is. And this is where it gets potentially quite startling for many people.
Lay it on us.
The headline finding, the big conclusion from both the systematic review and the guideline based on it, was this. They found no high certainty evidence that any of the common interventional procedures provided important pain relief or benefit on any other key patient outcome.
Wait, say that again. No high certainty evidence of important benefit for any of them.
For any of the ones they reviewed, joint injections, epidurals, radiofrequency muscle injections, for either axial or radicular chronic non-cancer spine pain. No high certainty evidence of important benefit.
Wow. Okay. That's a big statement. So what does that actually mean? Does it mean they definitely don't work?
Not quite definitely don't work, but it means the best quality evidence we have doesn't confidently show they provide a meaningful benefit beyond potentially a placebo effect.
Right.
For most of the common procedures, the evidence they did find was mostly low to moderate certainty.
Less sure evidence.
Right. And that evidence generally showed very little to no difference in pain relief when compared directly to getting a sham procedure.
So compared to a placebo injection, for instance.
Exactly. Like for epidural injections with local anesthetic and steroids, or the joint-targeted steroid injections for axial back pain, the moderate certainty evidence suggested they offered little to no additional pain relief compared to getting a sham injection.
So any relief people felt might just be the placebo effect, or maybe just the natural course of the pain getting better on its own.
That's what the comparison against sham procedures strongly suggests, yeah. And it was a similar story for radicular pain, that shooting pain. Moderate certainty evidence indicated that epidurals, or that dorsal root ganglion radiofrequency, probably made little to no difference compared to a sham.
What about things like the radiofrequency for the facet joints? the nerve ablation.
For those, the evidence was even weaker, only low or very low certainty according to grade, which basically means we know even less, the studies aren't great, but the limited evidence available doesn't show a clear benefit there either.
And it wasn't just pain, right? What about physical function? Being able to move better?
Same pattern, really. For example, for those joint-targeted injections for axial pain, moderate certainty evidence showed little to no difference in physical function compared to sham.
Okay, so the core message coming out of this massive review is when you rigorously compare these common procedures to a placebo, the best evidence suggests they don't add much, if any, specific benefit for pain or function.
That's the essence of the effectiveness findings, yes. And remember, the panel didn't just look at effectiveness. They had to balance that against other factors.
Right, the harms, the burden, the costs. Let's talk harms first. What did they find there?
Well, the trials themselves, as we mentioned, weren't ideal for tracking harms comprehensively. But pulling from other studies, they found low certainty evidence indicating a small risk of what they called moderate harms.
Okay, like what kind of things? And how common?
Things like prolonged pain or stiffness around the injection site, lasting more than 48 hours, that occurred in maybe 8.6% of people in some studies.
Almost 1 in 10, okay.
Temporary altered consciousness, maybe feeling woozy or out of it for a bit, around 2%, accidentally puncturing the membrane around the spinal cord, which can cause nasty headaches, maybe 1.4%, and getting a deep infection, thankfully rarer, maybe 0.7%.
Not super common, but definitely not zero risk either.
Exactly. And importantly, the panel also explicitly acknowledged the very rare but potentially catastrophic complications, even though the trials couldn't put precise numbers on these.
Things you hear about anecdotally or in case reports.
Right. Things reported in databases like the FDA's adverse event system. We're talking about things like paraplegia, actual spinal cord injury, meningitis, stroke, even death. Extremely rare, but devastating when they happen. There are real risks associated with putting needles and instruments near the spine.
Okay, so real harms, even if mostly small or rare. What about the burden aspect?
That's the practical side for the patient. These procedures generally aren't cures, right? They don't fix the underlying problem.
So you have to keep getting them.
Often, yes. Repeat visits are usually necessary. Injections might be needed every few weeks or every few months. Nerve ablations might last longer, maybe 6 months or so, but even those often need repeating eventually.
And each time that means?
Travel, taking time off work or away from activities, the discomfort of the procedure itself, it adds up. It's a significant burden for someone already dealing with chronic pain.
And then there's the cost, which we touched on. They're not cheap procedures.
Not at all. Very expensive, both for healthcare systems and potentially for patients directly, depending on insurance coverage and copays. Significant out-of-pocket costs are possible.
Okay, so let's pull this all together. The panel looked at the evidence. Little to no proven benefit over placebo for pain or function. They'd looked at the harms. Small but real risks of moderate issues, plus rare catastrophic ones. They considered the burden, repeat procedures, time, discomfort, and the high cost. What was their final conclusion, their recommendation?
Based on weighing all of that, the balance of limited to no proven benefit versus the harms, burden, and cost, the guideline panel issued a strong recommendation against the use of these common interventional procedures for chronic non-cancer spine pain.
A strong recommendation. That sounds pretty definitive for a medical guideline.
It is quite definitive. Their reasoning essentially was framed from the perspective of a well-informed patient.
Okay.
They concluded that if a typical patient understood the evidence, the lack of strong proof for benefit beyond placebo, the potential harms, even if small, the hassle and time involved in repeat procedures, and the cost, then almost all such informed patients would likely choose not to have these procedures.
They felt the downsides and uncertainties just outweighed any potential unproven benefits compared to a sham.
That was the panel's conclusion, yes.
Okay. So you have this highly respected journal, the BMJ, publishing this rigorous review and a strong recommendation against these widely used procedures. You can probably guess what happened next, right?
Oh, yeah. The reaction was, well, let's just say it wasn't quiet. The sources document a very strong, very swift response, particularly from the medical groups representing the clinicians who actually perform these procedures.
What did they do?
34 medical professional societies banded together. 34. And they jointly called for the BMJ to retract the guideline entirely.
Retract it. Wow. What grounds? What do they call it?
They labeled it misleading and irresponsible.
Strong words. What were their main arguments, their main beefs with it?
They had several key criticisms. A big one was methodological. They argued the meta-analysis was flawed because it inappropriately lumped together data.
Lumped, meaning?
They combined results from different types of procedures, different types of patients, axial versus radicular pain maybe,
Yeah.
different areas of the spine, things the societies felt should be analyzed separately. They argued this lumping obscured the benefits that do exist for specific procedures in specific patient groups.
So they felt the analysis wasn't granular enough.
Kind of, yeah. They also claimed the review included studies using outdated techniques, that it missed other relevant studies that did show positive results, or even that the BMJ authors extracted data incorrectly from some of the included studies.
Basically challenging the data and the methods.
Right. Their fundamental position was, and is, that these procedures do work, but the key is appropriately selected patients. They felt the BMJ review failed to capture that nuance and identify who those patients are.
Okay, that's a strong pushback. How did the authors of the BMJ review and guideline respond? Did they back down?
Not at all. They stood firmly by their work and their methodology. Regarding the lumping criticism, they countered that they did actually perform subgroup analyses.
Looking at those different patient groups and spine regions.
Exactly. And they said those subgroup analyses did not find any consistent systematic evidence that effectiveness differed significantly across those groups. The overall pattern of little to no benefit held up.
Interesting. What about the claims of outdated studies or missed studies?
They defended their study selection as representing common current practice. And they essentially put the challenge back to the critics. They said, okay, if these procedures work so well for appropriately selected patients, then show us the high-quality evidence demonstrating how to reliably identify those specific patients beforehand. Where's the proof?
So a defense of the methods and a call for better evidence from the critics. What about the BMJ journal itself? Did they bow to the pressure to retract?
No. The BMJ stated clearly they had no plans for retraction. They said they would follow standard scientific publishing practice, publish the society's critiques alongside the detailed responses from the guideline authors, allowing the scientific community and the public to see the debate play out.
Open debate. Okay. This whole situation really throws that tension into sharp relief, doesn't it? Between this very rigorous, systematic look at the evidence and then the real-world clinical experience and patient perspectives.
Absolutely. And when you look at the comments and responses published alongside the BMJ articles, you see that diversity of experience loud and clear.
What kinds of things were people saying?
It's a real mix. On one side, you hear from patients who are like, yeah, I had those injections, they did absolutely nothing for me, or I just got side effects. They felt vindicated by the guideline.
Okay.
But then you also hear these really powerful stories from other patients and clinicians too, who say, wait a minute, these procedures gave me my life back, or they provided significant relief, even if it was temporary.
So people who did feel they benefited.
Yes. For them, that temporary relief was incredibly valuable. Maybe it helped them function better day to day. Maybe it let them reduce their opioid use. Maybe it kept them from needing major surgery. They see real value there.
I also saw some doctors mentioning they use injections sometimes diagnostically.
Right. Not necessarily expecting a long-term cure, but using an injection into a specific spot, like a facet joint, to see if numbing that area temporarily relieves the pain. If it does, it helps confirm that that spot is the pain generator, which might guide decisions about, say, surgery later on.
That makes sense as a different goal.
And then there's this really big practical worry that came up a lot in the responses.
Which is?
If insurance companies see this strong recommendation against these procedures, they might just stop covering them altogether.
Which could harm those patients who do feel they get benefit.
Yeah.
Even if the science says it might be temporary or partly placebo.
Exactly. That potential impact on access and coverage is a major concern for many clinicians and patients who value these interventions.
And you also see people just fundamentally disagreeing with the meta-analysis methods.
Yep, some commentators dive deep into the statistical methodology, arguing it's flawed, and you get these very compelling personal anecdotes. Someone saying, radiofrequency ablation was life-changing for me, Hard to ignore those individual stories.
It really brings up that question again, what counts as success? Does temporary relief count? Especially if it makes a big difference in someone's quality of life, even if the mechanism isn't purely the specific effect of the drug or procedure beyond a placebo response.
It's a really tricky question, philosophically and practically.
So, given this complex picture, the contested evidence, strong reactions, Where does the BMJ work suggest we should go from here? What about future research?
Well, the guideline itself definitely calls for more research, especially for those interventions where the current evidence was judged to be really weak, low, or very low certainty.
Like the joint radiofrequency ablation you mentioned?
Exactly. Or some of the intramuscular injections. We just don't have enough good data on those yet, according to the review. Or high-quality studies are needed there.
And they wanted better outcome measures in future trials, right?
Yes, strongly emphasizing the need for future trials to capture that broader range of patient-important outcomes we discussed earlier, not just pain scores and maybe a walking test.
But things like emotional well-being, sleep, ability to participate in life, opioid use.
All of that, a more holistic view of benefit. And critically, they stress the need for much better evidence specifically on the risks and adverse events.
Better tracking of the harms.
Right. The trials included in the review often just weren't designed well enough to fully capture the frequency and severity of potential harms. We need studies that do that better.
Okay. So after this deep dive, where does that leave us?
Well, I think we're left with this really clear tension, aren't we? On one side, you have this incredibly rigorous, large-scale, systematic review, concluding that many of these very common, very expensive interventional spine procedures likely offer little, if any, specific benefit beyond a placebo effect for chronic pain.
Based on the best available evidence compared against sham procedures.
Right. And that finding and the strong recommendation against use that came from it stands in pretty stark contrast to decades of established clinical practice.
And the whole industry that's grown up around these procedures.
Absolutely.
Yeah.
And it also contrasts with those compelling personal stories from patients who genuinely feel they've benefited, at least temporarily.
So the core takeaway from this major BMJ work seems to be, based on their comprehensive review, the current best evidence suggests these common spine injections and nerve procedures probably don't provide much specific pain relief beyond what you'd get from a placebo.
That's the crux of it, yeah. Which inevitably opens up some really fundamental questions for everyone involved: patients, doctors, healthcare systems, insurers.
Like, given this evidence, given the costs, the burden on patients, the potential harms, how should we be managing chronic spine pain going forward?
Should the approach evolve? Should we perhaps rethink how different types of treatments are valued and reimbursed?
Comparing these procedures maybe to non-procedural options like high-quality physical therapy, exercise programs, psychological approaches like cognitive behavioral therapy, should the balance shift?
That's a huge question about resource allocation and priorities.
Yeah.
And maybe the most difficult question of all, the one for you listening and for clinicians wrestling with this.
Yeah.
What does it truly mean when the best available scientific evidence gathered systematically seems to clash so dramatically with long-held practices, financial realities, and deeply felt personal experiences of finding relief? Even if that relief is temporary or perhaps partly placebo-driven, but still subjectively real and valuable to the person experiencing it.
That's a lot to think about. How do you reconcile that gap between the aggregate data and the individual experience?
Exactly. There are no easy answers there, but it's definitely something worth mulling over as we think about the future of chronic pain care.